And the bone and joint infections are non-specific infection. That means that these are infections produced by standard, normal biogenic germs, bacteria, like, I don't know, Staphylococcus, Streptococcus, Pseudomonas, Klebsiella, etc. And this kind of germs will produce acute osteomyelitis, acute arthritis, or chronic osteomyelitis and osteitis. And we have specific infections produced by special germs like Mycobacterium tuberculosis that produce tuberculosis, of course, and we are interested in osteoarticular tuberculosis. The osteomyelitis, that means the infection of the bone, the infection of the medullary marrow, but also of the cortices, can be classified as suppurative osteomyelitis or non-suppurative osteomyelitis. The difference between the two is that in the first case, the infection will produce pus, and in the second instance, the infection will not produce pus. The suppurative osteomyelitis can be acute or chronic, and the chronic osteomyelitis can be primary or secondary. The primary chronic osteomyelitis doesn't have a preceding phase, an acute phase. It is chronic from the start, from the beginning. It is produced by a non-aggressive germ, and the body, the host body, is able to contain the infection. The secondary chronic osteomyelitis has a first acute phase. We have an acute osteomyelitis which wasn't well treated, and it evolves towards a chronic osteomyelitis. The non-suppurative osteomyelitis has a number of clinical manifestations like diffuse sclerosing, focal sclerosing, proliferative periostitis, and so on. The first topic for today, the acute osteomyelitis. It appears mainly in children, and it is usually localized near the knee. That means in the distal part of the femur and in the proximal part of the tibia. It is 2 times more common than acute arthritis. It is a bacterial bone infection, and in most cases it is produced by Staphylococcus aureus. That represents around 80% of all cases of acute osteomyelitis. The evolution can be severe, but it can be mitigated, of course, by early diagnosis and proper treatment. For the acute osteomyelitis in children, we must have an entry point. And usually this entry point is a skin lesion, a skin cut, an insect bite, a furuncle, and so on. Or we can have an infection site at distance, so not at the level of the bone or of the joint, but in some other organs, like an amygdalitis, pharyngitis, infection at the level of the lungs, urinary infection, so on infection site at distance. And the second step is the hematogenous dissemination. The bacteria will go through the blood, and it will locate at the level of the bone. Usually, the metaphyseal areas are affected due to their abundant blood perfusion at the level of the growth cartilage, and another site of dissemination are the joints. There is a favorable role of the trauma. We have an infection site. this infection site will discharge bacteria in the blood flow. If the patient has a trauma at the level of a joint, that will lead to thrombosis of the veins at this level. The blood flow will slow down. That will lead to a local accumulation of germs, and that will lead to an infection at the level of the metaphyseal areas. In children, the most affected joints are the knee, the hip, and the shoulder, like on the left part of our body, and they are colored in red, so knee, hip, shoulder. While in the adult, the most affected joints are, or the most affected areas are the femur, the spine, and the foot. At the onset of this disease, the patient will present general signs and symptoms, like the infectious syndrome caused by bacteremia, and that means fever of 39-40 degrees. Shiver, the shiver is a sign of bacteremia, and if the patient will present shiver, we will harvest blood cultures in order to identify the germ in blood. The patient can also present headache, impaired general condition, loss of appetite, and so on. So general signs and symptoms. Of course, that we will have also local signs and symptoms. From the medical history, the patient will describe acute localized pulsatile pain, and this pain will be more severe during the night. At the clinical examination, we will have inspection and palpation. At the inspection, we will see swelling and hyperemia, while at palpation, we will feel pain and hyperthermia. Local pain, local hyperthermia, of course. From the biological point of view, we will have increased sedimentation rate, reactive C protein, leukocytosis with polynucleosis, and fibrinogemia. All these are signs of inflammatory and infection response from the body, from the host body. We will harvest, as I said, blood cultures if the patient will present shiver, and we will punctuate the site of the infection. We will extract some liquid from there, and from this liquid, we will perform a smear, cultures from the extracted liquid, and also antibiogram. All these procedures have the goal to identify the germ, but also its sensitivity for different antibiotics. In the image on the right, above, you have a smear, and you can see there some bacteremia. In the middle, we have cultures from the extracted liquid, while below we have an image from electronic microscopy with images of Staphylococcus aureus. They are gold, as you say. As I said, the most frequent identified germ is Staphylococcus aureus. That's why we have this image here. This clinical entity, the acute osteomyelitis, is rare in young adults, and all localization are possible. The contributing factors for the appearance of this disease in young adults being general state of weakness, chronic disease, drugs use, and so on. It can occur also in adults, in many cases after genitourinary infections with gram-negative germs, And the usual contributing factor in adults is peripheral vascular insufficiency. At the onset of the disease, the radiological examination will be negative. So there are no radiological signs at onset. The radiological examination will be positive much later. As you can see in the images, in the left, we have an image from the 15 days after onset. At the level of the calcaneum, there are no osseous lesions, while on the right, after 60 days, we have a lesion, an osteolytic lesion in the posterior part of the calcaneum. In the middle, we have an image from the bone scintigraphy, which is positive from the onset. So the bone scintigraphy can provide us an early diagnosis of such a disease. We have different types of scintigraphy. We have the standard scintigraphy with a standard radioactive tracer that will accumulate in the affected area. But this kind of imagistical examination is non-specific. If you have such an image with a radioactive tracer accumulated in a part of a body, that means that something happens there, but you don't know if it's an osteoarthritis, a tumor, an infection, and so on. It only says that there is something there. In order to surely identify an infection, you must use radioactive marked leukocytes. If you have accumulated marked leukocytes in a part of a body, you can be sure that there is an infection there. Images from bone scintigraphies, you can see accumulation of the radiotracer in different parts of the body, at the level of the hip, at the level of the knees. You don't know what happens there. Probably there are normal osteoarthritis for a patient. But in the middle, we have an image in red. We have an image from a bone scintigraphy with marked leukocytes, with accumulation at the level of the knee, and you are sure that we have an infection, an acute osteomyelitis at this level. The MRI can provide also early signs of osteomyelitis, and in this image you can see osteomyelitis inside the bone, but also an abscess in the soft tissue around the bone. The histopathological examination can provide also information about the infection, and we have some images here with pus, with the necrotic bone marrow and necrotic cortices. The treatment. The treatment consists in adapted antibiotics on the antibiogram obtained by culture and antibiogram. And the usual treatment is 2 antibiotics by intravenous therapy for 6 weeks. Why so long? Because the bones cannot defend themselves against an infection. This is why in bone infection, we will use longer antibiotic therapy. After that, after the first 6 weeks with intravenous therapy, the patient will take oral antibiotics for 6 months. And in many cases, even this longer antibiotic therapy will not heal the infection. This is why we are so obsessed by all these antiseptic measures in orthopedics. And of course, we will call the patient for biological and radiological periodical checkups. The best healing is achieved by early and properly treatment. As you can see in the image, we have an infection, an osteomyelitis at the level of the distal part of the radius in children. You have many growth plates at the level of the hand. And on the right, we have an image after 5 months with the healing of the bone lesion. A peculiar case of acute osteomyelitis is the subperiosteal abscess. It is a localized purulent inflammation of tissues that leads to their dissolution and the formation of a pus-containing cavity. If it is not treated, it can open outside the body or in a cavity, a joint cavity in our case, forming a fistula. If it doesn't discharge by itself, surgical incision and drainage is required, because without these discharges, it cannot heal. In the case of subperiosteal abscess, at the clinical examination, we will have the same general signs and symptoms, like oscillating fever, sometimes shivers, fatigue, pallor, loss of appetite, and so on, and the classical signs of inflammation and infection, rubor, calor, tumor, dolor, and frictionlesa. And because we have an abscess, we will palpate also local fluctuancy. The ultrasound will reveal the presence of the abscess, periosteal decollation, and edema at the level of the adjacent soft tissues. At the radiological examination, on onset, we will see only soft swelling, a mild swelling, without any lesion at the level of the bone. But in time, we will see stained bone aspect and periosteal reaction like in the images. In the first three, we can see these stained bone aspects and a periosteal reaction, while in the second image, we have the stained bone aspect at the level of the proximal diaphysis of the tibia, and here we have the growth plate. So it's a child. At the MRIs or the CT scan, we will see the same things, stained bone aspect and periosteal reaction. On the left, you can see the abscess here around the tibia and the periosteal reaction. And we can see here the same thing in a sagittal slice. The subperiosteal abscess is located somewhere in the middle third of the tibia on its posterior aspect. It's the thing in a darker gray here. In order to diagnose the subperiosteal abscess and in order to identify the bacteria, we will perform a puncture, we will extract some pus, and this will allow us to perform a smear, a culture, and an antibiogram. This is an image from two different smears. On the left, we have gram-positive cause, like in Staphylococcus aureus, and on the right, we have gram-negative bacilli, like Klebsiella. An image with a culture and antibiogram. As you can see, we have the culture, we have pills with different antibiotics, and these antibiotics will kill the bacteria around the pill for different distances. And this is how you can say which is more effective against this kind of bacteria. You can see that the halos around the pills are different. Some are smaller, some are bigger. If the halo is bigger, of course, that this peculiar antibiotic is more effective against this bacteria. Different examples with radiological signs for osteomyelitis. Here we have a patient, a male patient of 15 years. We have acute osteomyelitis after a finger wound with sclerosis of the first phalanx and periosteal reaction. The periosteal reaction is this gray image around the bone. Other image, neonatal osteomyelitis at the level of the left femur, metaphysialysis with periosteal reaction in the proximal part of the tibia. Here we have the growth plate. This is the bone osteolysis, and here we have the periosteal reaction. And another image in a patient, in a male patient of 13 years old, after a knee wound, we have osteolytic lesion at the level of the distal epiphysis of the femur. The evolution of acute osteomyelitis without treatments is towards the formation of a fistula, that it's an abnormal connection between the abscess and the exterior, or a cavity. In our case, in the osteoarticular osteomyelitis, this cavity is represented by a joint. Other evolution are towards bone necrosis with the formation of some sequester, chronic osteitis, and skin eczema. And different images. On the first image, we can see here a sequester. That means a fragment of necrotic bone. Here we have chronic osteitis with the formation of a sequester, here a necrotic bone, and this is the part of the bone, the sequester, the necrotic bone after excision, and an image with skin eczema above an acute osteomyelitis. Other radiological appearances are the image of a coccade. That means osteolytis and osteocondensation one around another. Periosteal thickening, like here, or best seen here. And cortical thickening. The treatment includes, of course, the antibiotherapy, but also some surgical treatment. And surgical treatment will include the excision of the sequester of these fragments of necrotic bones curettage, debridement, and drainage. And in time, the so-called guided spontaneous healing. Sequestrectomy. We already saw this image. This is the sequester, a fragment of necrotic bone that must be excised. And these are the post-operative images after the excision of the sequester. Some cases, one male patient, 70 years old, that who describes pain after a rugby game, then fever with a warm, painful, swelling arm, and then fluctuant. It has here an acute osteomyelitis. We perform a puncture that extracted pus from the lesion. We perform cultures and antibiogram, antibiotic treatment, targeted antibiotic treatment against this bacteria. And here we have evolution at the start, after 15 days, after 20 days, after 30 days, and after 40 days. As you can see, the evolution is very long for an infection. And that means nothing, because there are cases in which the infection will evolve for years, or even for decades, or even for as long as he or she lives. So it's a very severe health problem. After 45 days, we can see necrosis, but also reconstruction. Sequestrectomy was performed. As you can see on the right, there is a part of the bone which is missing here. That was the sequester, the necrotic bone. The image after sequestromy and the image after 15 days after surgery. And you can see that after this surgical procedure, the evolution is faster towards healing. And finally, the image after 45 days after surgery with healing of the bone. Other examples, an extensive acute osteomyelitis of the tibia, curettage, debridement, drainage, the bone is exposed to lavage, and this is the image after 1 month of surgical and antibiotic, surgical treatment and antibiotic. The clinical evolution right after surgery, at 2 weeks after surgery, at 1 month after surgery, and after 2 months after surgery. The same case, the radiological evolution towards healing. Another case with spinal osteomyelitis in an older females of 55 years old, spondylodiscitis with Escherichia coli, and after antibiotherapy for 2 months. The spinal osteomyelitis will evolve towards full destruction of the disc and partial destruction of the two adjacent vertebral bodies. The evolution will be towards healing if you treat it well with surgical and prolonged antibiotic treatment, but it can have also recurrences and the evolution towards abscess. The complications are multiple bone localization, abscesses in distant sites like at the level of the brain or of the lung, septicemia, and endocarditis. The local complications are cold diaphysis infection, the so-called pandiaphysitis, arthritis with the germ disseminating inside the adjacent joint, and the patient can present also lesions at the level of the growth cartilage, like here on the right. Here is the growth plate, and here we have an infection with lesion of the growth plate that will lead to an epiphysiodesis, and that in time will lead with an misalignment of this knee, because this affected growth plate will not grow, while the other one on this side will continue to grow, and that will lead to a misalignment in varus. If the whole growth plate is affected, that will lead to the closing of this growth plate with a low length discrepancy, because this lower limb will remain shorter because this growth plate was closed much more quicker because of the infection. So the lesions at the level of the growth plate can lead towards a complication that will lead to misalignment and lower limb length discrepancy. Other examples, here we have a pandiaphysitis with periosteal reaction here. Here we have an arthritis with the destruction of the humeral head. Other local complication, bone necrosis. In this case, we have the disappearance, the total disappearance of the femoral condyle. So this knee is distracted. As I said, bone shortening with upper or lower limb length discrepancy and misalignment and osteoarthritis that will lead to osteoarthritis of the adjacent joints in time. On the left, we have pandiaphysitis of the radius with misalignment. On the right, we have pandiaphysitis of the femur. As you can see, there are bone lesions in the whole femur with misalignment, but also with shortening of this femur with lower limb length discrepancy. Till now, we spoke about acute osteomyelitis. The second topic for today is chronic osteomyelitis. As we already saw in the first classification, this can be a secondary chronic osteomyelitis if it appears after a prolonged evolution of acute osteomyelitis without proper treatment. It can appear after infected surgical prosthesis, infected fractures, or infected metallic implants. The chronic osteomyelitis from the beginning doesn't have an acute phase, and it is usually generated by an infection with a low virulent microbial germ. The host body can contain the infection, and that will lead to a chronic osteomyelitis from the beginning. The clinical aspect of chronic osteitis with a fistula, and you can see pus inside the fistula. The secondary chronic osteomyelitis will have a long evolution. It will lead to necrosis and peripheral bone formation, and it will have periods of acutization. Long evolution means months, years, decades, and even longer. The chronic osteomyelitis from the beginning doesn't have an acute phase, so it doesn't have a noisy onset as in acute osteomyelitis, and it can have a number of forms, and these are hyperostosis and necrotising form, the central bone abscess as described by Brody, the hypertrophic osteitis, and the osteofluent abscess, the so-called albuminosis form. Examples. Example for an hyperostosis and necrotizing form. In the middle of the bone, we have necrotic areas, but we have around the bone hyperostosis. Hypertrophic osteitis, we don't have osteolytic lesions, but we have an hypertrophic bone at the level of the radius in this case. The central bone abscess, as it is described, it's a lesion inside the bone, in the middle of the bone. So the clinical signs are diminishing, but at the radiological examination, we will see an osteolytic lesion in the middle of the bone, inside the bone, like here for the patella or here for the radius. Other images with Brody central bone abscess, you can see these osteolytic lesions, round or oval lesions inside the femur, or here inside in the proximal third of the femur. In the middle, we have an osteolytic lesion surrounded by hyperostosis, by newly formed bone. Other images with the Brody abscess. Here we have one in the distal part of the tibia. Here we have an MRI image with a sagittal slice. You can see here the localized infection in the middle of the distal tibia. The treatment will be an association between the surgical treatment and antibiotic treatment. The surgical treatment will consist in debridement, drainage, guided healing, sequestrectomy, and removal of all foreign implants. That means prosthesis, metallic implants like, I don't know, nails, plates, screws, wires, and so on. Because if we don't remove all foreign implants, and that it does include also cement, if we remove all the foreign metallic or cement implants, in some cases the infection will not heal. But if the metallic implants are on site, you are sure that the bone infection will not heal. The evolution is very, very long, sometimes lifelong. Our third topic for today is the infection arthritis, and we will have a fourth, which is tuberculosis. For an infectious arthritis, we must have a source of the intra-articular germs. And we have two different cases: the direct inoculation by an articular wound or by articular puncture or articular infiltration, and this is the direct inoculation, or we can have the indirect contamination by the blood supply, by the hematogenous way, from a distance infection site, an abscess, which can be a dental one, a lung abscess, an infection like a furuncle at the level of the teguments, a urinary infection, amygdalitis, pharyngitis, germs from the bowels, and so on. At the clinical examination, we will have general signs and symptoms and local signs. The general signs and symptoms are fever, shiver sometimes, fatigue, loss of appetite. The local signs are the classical described signs of inflammation or infection, and these are rubor, calor, tumor, dolor, and functionalesa. The treatment will be surgery and antibiotic treatment. The surgical treatment must be performed before the patient will have cartilage damage and bone destruction. The surgical treatment consists in debridement, drainage, synovectomy by open surgery or by arthroscopy, because this synovium represents a deposit of germs. So in an infection arthritis, you must remove the synovium. And in time, of course, that the joint will produce another synovium. Antibiotic treatment, it's a long antibiotherapy, at least for two weeks, in some cases 4 or even 6 weeks. Our last topic for today is the skeletal tuberculosis. The skeletal tuberculosis, the osteoarticular tuberculosis, represent around 30% of cases of extrapulmonary tuberculosis. The location is at the level of the spine, and in most cases, but it can affect also the great joints of the lower limb, usually the knee, but also the hip and the ankle. It's an infection produced by Mycobacterium tuberculosis. The spinal tuberculosis is called also the Pox disease. The most frequent location is at the level of the thoracic spine. The infection will lead in time to the destruction of the intervertebral disc and the adjacent vertebrae that will lead to anterior wedging and kyphosis with the forming of the so-called gibbus. If the infection, if the tuberculosis is not correctly treated, that will lead to paraspinal and psoas abscesses. On the left, you can see images from an MRI with a tubercular discitis with the destruction of this intervertebral disc, and the infection goes in both the above and below vertebrae with bone destruction at this level. On the right, you have another image from a CT scan, and in the red circle, you can see a paraspinal abscess, an abscess which is located right on the spine in the psoas muscle. That was the spinal tuberculosis. The articular tuberculosis is in most cases a slowly progressive monoarthritis of the knee or of the hip. At the clinical examination, we will see pain, joint swelling, and decreased range of motion. It is also called the white articular tumor because it mimics a tumor. In chronic cases, we can see abscesses, periarticular abscesses, and fistula, and the systemic symptoms are usually absent. At the radiologic, we will see soft tissue swelling, juxtaarticular osteopenia, like in the image, joint space narrowing, and subchondral erosions. The diagnosis. The diagnosis in the osteoarticular tuberculosis is based on the identification of Mycobacterium tuberculosis. We will perform a punction, and from the extracted liquid, we will produce a smear with a specific staining, which is the Thiel-Nielsen staining. On the right, you can see an image from a Thiel-Nielsen staining, and the bacteria which are in purple are Mycobacterium tuberculosis. From the same extracted liquid, we will perform cultures on special mediums, and the most used medium for Mycobacterium tuberculosis is the Lowenstein-Jensen media. And on the right below, you can see an image with cultures, with colonies from Mycobacterium tuberculosis, and in the middle you can see an image with such colonies. Another method of identification of the Mycobacterium tuberculosis is the PCR, the polymerase chain reaction. In this kind of analysis, we will identify the DNA of the Mycobacterium tuberculosis. Other two methods of identifications are to identify the antibodies from lymphocyte secretion assay or from the interferon gamma release assay, and this method will identify the antibodies made by the host body against Mycobacterium tuberculosis. Another method of diagnosis is the biopsy. You can perform also PCR or even cultures from the bioptic material, but if you perform a histopathological examination of the harvested bone fragment, you will identify caseous necrosis. In this case, no histological architecture is preserved, and the caseous necrosis, as the one that you can see in the image indicated by the arrows, this caseous necrosis is specific for tuberculosis. If the pathologist can identify this caseous necrosis, you can be sure that there is a tuberculosis infection in the area. We have another diagnosis test called the Mantoux test. This is widely used in the world. It involves injecting a small amount of PPD tuberculin into the skin of the patient. It is also called the tuberculin skin test. Normally, all of us are vaccinated against tuberculosis, and that will lead to a reaction in the skin, but this is a smaller area. If you have an active tuberculosis, the red area will be greater, and you can have also a pustula like in the image. So after the injection of the tuberculin in the skin of the forearm, you can have 3 instances. No reaction. That means that your vaccine is no longer active. You are not protected against tuberculosis. In most cases, a small reaction. That means that your vaccine is active and you are protected against tuberculosis. And in the third instance, you have a larger area with pustula, and in this case, you have an active tuberculosis somewhere in the body. You must perform a chest X-ray and you must search for tuberculosis, osteoarticular or not. The imagistical diagnosis means radiological examination, MRI or CT scan. At the radiological examination, you will see irregular osteolytic lesions and articular destruction. And we can see here osteolytic lesion at the level of the medial cuneiform, osteolytic lesion at the level of the distal radius in a child, or osteolytic lesions at the level of the cuboid bone. At the MRI examination, you can see articular destruction and abscesses in the soft tissues. Here we have destruction in the calcaneum, in the navicular, and in the cuneiforms. It's an image for an MRI. It's a sagittal slice. Another image, also a sagittal slice, with lesions with tuberculosis at the level of the medial cuneiform. And another image also from an MRI at the level of the lumbar spine between the fourth and the fifth lumbar vertebrae. You can see tubercular infection with the destruction of the intervertebral disc, but also with the destruction of the above and below vertebral bodies. The treatment. The usual treatment is antibiotherapy, which two antibiotics, which are isoniazid and rifampicin for 6 months, and two additional antibiotics, usually pyrazinamide and or ethambutol, for the first 2 months of the 6 months treatment period. So, in this case, we have also a very long antibiotherapy, 6 months, and 6 months at least, because in some cases, in severe cases, or in cases with resistant Mycobacterium tuberculosis, the treatment can be prolonged to 1 year or even longer. The surgical treatment will consist in debridement, drainage, joint reconstruction, or posterior transpedicular instrumentation in spine. And here you have two examples. In the first one, total knee arthroplasty after destruction of the knee joint by an tuberculosis, and in the second case, total hip replacement with an uncemented total hip prosthesis after tuberculosis of the right hip. Thank you for your attention. That will be all for today. If you have questions, please. Anything?
It was clear. Thank you.
Okay. So you hear me to the final?
Yes.
That's a good one. Okay. Thank you for your attention. Have a nice day.
Thank you.
Thank you. You too.
Thank
You're
you,
welcome.
doctor.